Hi, my name is Dan Gomez, and this is Mental Health Supra Omnia. Mental health above all. We identify and understand mental health issues and the paths for help. According to the CDC, about 50,000 people die by suicide each year in the United States. 12.8 million have seriously thought about suicide. 3.7 million actually made a plan, and a little less than half of that attempted suicide. Not only is this a tragedy for those who contemplate, attempt, and commit suicide, it is utterly devastating to those loved ones, friends, and acquaintances left behind. To discuss this issue, we have Bryan, a leading expert in the area. In fact, may even be the leading expert in the United States. He's currently professor of psychiatry at the University of Vermont College of Medicine. Craig wrote Rethinking Suicide, Why Prevention Fails, and How We Can Do Better. Craig, do we know why this is happening, and is it predictable?
Well, I would argue that no, we don't entirely know why it's happening, because I think if we did have an explanation, understanding, we probably would have identified strategies that would have been more successful at preventing suicide. And I think in regards to your second question, is can we predict suicide? That's a matter of debate. I think there are a lot of researchers who certainly are working on prediction models and different strategies for doing that. And then there are other researchers, including myself, who would argue that prediction of suicide, at least as we kind of historically have thought about it and used that term, actually is not possible. And so we probably need to rethink and reconceptualize this notion of how do we identify people at risk for suicide, and what does that mean from like an intervention and a prevention perspective.
So Erica, let's bring in Erica. Erica Burgoon is clinical director of Equilibria Psychological in New Jersey. She has a psychology PhD and years of service helping clients. Erica, what's your reaction to Craig's position about suicide at this point in time?
Yeah, I want to talk about it more today because as you said, Dan, the prevalence of suicide is rising. It's sort of tragedy on a large scale. It's a tragedy in the lives of those who are affected by it, of the survivors, of people who die by suicide. And in the face of a tragedy like this, we want to do something. We in the clinical world want to do something. People who are affected by this want to do something or want to know that there are things being done. And I think that one of those things we hope we can do is predict and prevent. And Craig, I hear from some of your work that maybe some of the ways that we think we understand suicide or have been educated to understand suicide may not have, pan out exactly as we think we've been told or we think we know. I also have to assume we can balance that message and say that it's not that there's nothing we can do, right? So I hope we can talk today about what you've learned in your career and what we can do with that information, how we can still continue to help people and address this, as we said, really tragic circumstances, both societally and on a personal level. And so I'd love to understand more about what you have learned about in your work.
Yes. So what I would say is right now, the way that we use the term prediction and we think about it is really captured by the notion of who's going to do it and when are they going to do it. And here I'd say, if we think of prediction in that way, then we're not really going to be very reliable. And the reason is just because despite how common suicide is in the United States, for instance, somewhere between 45,000, 50,000 people per year die by suicide, we have to keep in mind that is sort of the numerator, the denominator is like 360 million people. And so from that perspective, the sort of commonality or the percentage of people dying by suicide is actually quite small, and that from a mathematical perspective essentially eliminates the possibility of reliable prediction. But yeah, that's not to say that there's nothing that we can do to help people prevent suicide. We actually can. We have treatments and interventions that are remarkably effective for preventing suicidal behavior. But those treatments and methods, interestingly, do not hinge upon our ability to predict and know who or when something is going to occur. And so let's think about this in other areas of our life where we cannot predict outcomes, yet we are quite successful at, helping people, saving lives. An example I give is traffic fatalities. None of us knows when or if we will get into a car crash today, tomorrow, next week, things like that. And we certainly don't really kind of waste any money or resources trying to develop like machine learning models on who's going to get into a car crash when. And so because of the unpredictability of car crashes, we built safer cars. We built safer roadways. We have, driving classes, things like that. And those things in combination have saved a lot of lives. And likewise, we can't predict whose house is going to be leveled by a tornado or some other natural disaster. And we don't try to do that. Yet we have good weather alert systems, and we have procedures that we put into place depending on where we live. How are our houses and buildings constructed, right? And what are the things that we do when we know that a severe weather pattern is coming into our area? And so being able to, I think, disentangle and sort of detach right now what I think is this assumption that we must know who and when is going to do it in order to stop them, I would argue that's actually not very sound logic. And the good news is we could perhaps redirect a lot of resources towards things that do work, which could improve our success.
So Craig, I understand your analogy, but as a going in proposition, I would just have to think that if someone is thinking about committing suicide or is attempting to commit suicide or has actually committed, they must have had a mental health problem. Is that accurate, or is that totally inaccurate?
The data do not support that sort of monolithic claim. It is something that we've all, I think, kind of been learned, especially those of us in the mental health disciplines. And a statistic that I think most of us have heard is, like 90% of people who die by suicide or attempt suicide have some sort of like a mental health diagnosis, mental illness, something like that. But 50 years of research actually do not support that conclusion. What the data would suggest is that slightly less than half of people who die by suicide have a mental health disorder or condition. The other half appear to be experiencing extreme reactions to life, misfortune, disappointment, tragedy, unexpected stressors. And so we have, in essence, these different pathways that people can potentially follow to arrive at suicidal behavior. And that holds important implications for how we prevent suicide, because if we put all of our eggs into the mental health treatment basket, we will always miss the majority of people who are experiencing suicidal despair and killing themselves.
It's interesting. In my own experience, I was acquainted with somebody who, a young man who got an adverse medical diagnosis. He was losing his eyesight, something brand new. Didn't know that was going to happen. All of a sudden, he was having trouble with his eyes, got diagnosed, was going to lose his eyesight, and he killed himself. So it's exactly what you've said. Erica, what do you see in the field?
Yeah, so interestingly, one of the things I've seen throughout my career, and I imagine many of my colleagues have too, are folks who live for months, even years, even a lot of their life, thinking about suicide as an option. It crosses their mind at various times of high stress or otherwise, but they never attempt. They hold on to that. They know that that's an option, But again, and no attempts. And obviously, for many people, clinicians included, that's an uncomfortable place to be, knowing that someone is chronically thinking about suicide. But I'm thinking about what you're saying here, Craig, that it sounds like, and please correct me if I'm wrong, but you have seen folks who actually maybe weren't thinking about suicide long term. It was more circumstantial, maybe a shorter term thought before they attempted or completed. And so it makes me wonder about the difference between those who may hold the thought for years and never attempt, and those who maybe actually have not been holding that thought very long but do.
Yeah, it's I think what you're describing there is the experience of many of us who are mental health professionals, and I think that's because, right, the people who experience suicidal thoughts for long periods of time, who are struggling with depression, or their suicidal experience is sort of, couched within, mental health struggles. Well, they come to us for treatment, right? And so that's what we see regularly. And so I think it lends to that view and perspective. But of course, that's, there's a term for that, it's called selection bias, right? Because people without depression and anxiety, things like that, why would they come to a mental health professional, right? And so they don't come to hospitals and clinics. But there's this fairly consistent pattern in published research for, decades, showing that, something like half of people who attempt suicide did not plan it in advance, did not necessarily have active thinking. There's this interesting subset of people, varies from maybe 10 to 20%, depending on the study, who will actually say, I didn't have any thoughts of suicide or death before I tried to kill myself. It wasn't until after I had attempted suicide that I started thinking about killing myself, which seems so paradoxical. But if we, again, kind of look at sort of what is the phenomenon, the experience of like being suicidal, of acting upon this like urgent impulse that I have, it may be the case that there is a diversity of experiences. And a useful way of thinking about this, at least I find it useful, is to think about something that many of us have experienced, which is like losing our patience or losing our temper. And we might have become verbally upset. We may have yelled. Maybe we threw like our coffee mug or something like that. But it was this sort of in the moment reaction to the situation that was uncharacteristic or unusual for who we are as people. But it doesn't mean that we're necessarily violent or aggressive or impulsive or angry individuals. It was this sort of perfect storm that happened. And that sort of characterization I've heard from so many people, from family members and loss survivors, of we didn't see it coming. This was the last person we would have expected to do this. And I think it just kind of, I think is important for all of us to kind of think about sort of the diversity of experiences that might, precipitate or lead up to this end point of suicide. Because if this is the case, of course, what that means is we just have to be a little bit more nuanced in matching treatments, interventions, and prevention strategies to different pathways that people follow.
Yeah, it's uncomfortable to consider as a mental health professional. We are used to routinely screening people for suicide, but you seem to speak to experiences of someone, if I had screened them a week ago, 2 weeks ago, there may have not, appeared that they were at risk. And I am curious, even though we're talking that, we can't necessarily predict all attempts at suicide, have you learned anything through your work and your research about any commonalities, factors that may distinguish those folks who they have the thought and they act on the thought versus those who don't?
Yeah, I mean, So one line of research that I've been involved with now for probably a decade and a half was really focused on like baseline risk for suicide or latent vulnerability, where there are different terms that capture this concept depending on like your background training, but you might say like subconscious or unconscious vulnerability, things like that. But the work that we've done focused on like the suicide cognition scale. It's this like list of statements that David Rudd compiled based on work with suicidal patients, and that patients will say things like, "I deserve to die," and I can never be forgiven for the mistakes I've made, and I'm unworthy of love, and people would be better off without me. I can't take this anymore. This pain is too much to bear. And so these sort of expressions, this like mental state of vulnerability, we have found is actually a pretty good indicator. It's a better indicator than suicidal ideation of who is actually going to attempt suicide. But it operates on a different time scale. It behaves very differently from ideation as we've classically defined it and measured it. And so we have to, I think, kind of unmoor ourselves from this like very narrow focus that we have right now on suicidal ideation, because I think what we're heading towards, what we've done is we've like become so obsessed with, are you going to kill yourself? That's not what a lot of people experience. We have also trained our patients to not be honest about those questions.
Sure.
There are consequences that come with it. And incidentally, I wrote a study just within the past few months. You look at the United States, North America as a whole, it's true in Canada as well, we have the highest rate of concealment of suicidal ideation in healthcare settings. And the reason being is that in North America, patients have learned things happen when you report suicidal ideation. Those things might not be good, or at least, favorable for me. And so we also have this other problem, which is our obsession with preventing suicide in certain ways have led people to not be forthright with us. So we have to, I think, move beyond our narrow focus on suicidal thinking because of the realities of what our patients are comfortable disclosing to us. But secondly, because, as you noted, suicidal thinking comes and goes very quickly. And so it's going to be inherently limited as a detection tool.
Yeah, there certainly is a discomfort in the medical field and beyond when someone endorses suicidal thinking to not take the most extreme option of looking at, something like hospitalization. And so that makes sense and is also alarming to hear that we have essentially socialized people out of reporting their suicidal thinking and the opportunity to help them with that.
Yeah.
Craig, earlier you mentioned or you used a phrase, you said lost survivor. Now, a lost survivor, correct me if I'm wrong, are those of us that are left behind, right? So what's happening from a mental health perspective to the lost survivors, to those of us that are left behind? What feelings, what issues, what mental health issues does that suicide engender? In one particular case that I know of, I know a parent who or had met a parent that absolutely denied that their child committed suicide. He had to have been murdered. But what do you see for lost survivors?
Yeah, so I mean, we see a range of responses. It mirrors what we see for other like grief reactions, right? You have some lost survivors, family members, loved ones, right, who experience anger. It's usually mixed with sadness. Oftentimes there's a lot of self-blame, guilt, shame. If only I had called, I should have, done something different. And what did I miss? It incidentally is a major reason why when I do a lot of, public speaking and education on this, I think we need to be much more cautious as a field about how we talk about warning signs for suicide, because again, suicidal states come and go quickly. And so when we hear from family members and other loss survivors, I didn't see it coming, I think we do harm when we say, well, there's always warning signs. All suicides are preventable. Man, that's a brutal message to hear, you know, as a parent, as a spouse, as a child, when in reality that maybe is not always the case. And so all that being said is there are these sort of pathways that loss survivors follow, and a big part of my work with them has been very heavily informed by the grief literature. And to say that there can be ambivalence, there could be a mixture of responses, there's no right or wrong way to react to it. And so a lot of it is written into a person's cultural background, their lived experience, their personal value systems.
Mm-hmm.
I really appreciate that you're bringing this piece of this work up. Both in clinical practice and in some of my personal experiences, that has actually been a fairly common refrain that we, for many, many years now, the overarching message has been there's always warning signs. And for someone who is the survivor of a loved one who has completed suicide, how invalidating, to be in the throes of, terrible grief and loss, and then to also hear there's always warning signs. And I just, can't imagine how invalidating and how that must compound someone's grief. I don't think that's said with an intention to blame, but certainly I think it's internalized that way by survivors.
Yeah. Yeah, I agree 100%. I mean, yeah, right. The intention behind it is more of trying to encourage action and hope, like we can do something to prevent this type of thing. But it sometimes lands the wrong way because of the implication associated with it. And, I often use, when I do talks on this, I have this clip of Simone Biles during a championship performance from many years ago. And we watch it, and then very suddenly, unexpectedly, in this particular competition, she fell off the balance beam. And what I like to highlight is we'll watch it, you see it go through, and then I go back and I freeze frame, the video. And I say, in retrospect, now that you know the outcome, it's obvious if we freeze frame, oh, look, she's off balance here. And a split second later, oh, she's very clearly going to fall. So these warning signs in retrospect are super obvious. In hindsight's 2020. But in real time, it happens so fast that you sort of can't process it, especially when you're watching the greatest of all time, right? And that's how many of us are affected by suicide. It often happens to people we were not necessarily expecting it to come from. And most people attempt suicide when they're alone, when they're separated from others. And so we're often not around to see that losing of the balance when it happens very quickly. And so that explains why it's not always foreseeable. It's difficult to predict. And this is the majority of suicides. And I just think we should be a little more honest about the phenomenon that we're trying to prevent here.
So what do you do, Eric? Somebody's spouse does commit suicide, or brother or family member of one sort or another. What happens then from a mental health perspective? How long does it take to come to terms with that? What do you have to do in order to come to terms with that?
I mean, I do think that's so individualized. We know that from all sorts of grief and loss work, not just survivors of suicide, but there is a unique layer or experience for those who have survived a loved one's suicide. I think one of the more important things we know from grief and loss work, right, is that too often in popular culture, I mean, you use the word come to terms with, we hear this word closure a lot. And it's, from my perspective, it's really a false concept. We don't, in any kind of grief and loss work, and especially this, survivors don't necessarily come to this point of, closure. There's nothing tidy about this. We hope to help people learn to live and live well, hopefully, eventually, with this new reality in their life. This reality that's not going to go away, that the loss of that person, the impact of that experience will always be felt, always be there. But we do hope when we're working with folks who are grieving, and particularly this kind of grief, that we can help them to, as I said, live well, live meaningful lives, live lives that can still be marked by periods of joy. How long that takes, I think people ask that a lot, right? And it really is so individualized.
So Craig, in your, you actually run a clinic, correct me if I'm wrong, in Vermont, for suicide, not for suicide, but for this area. What do you end up, do you deal with lost survivors? What do you say to them? Or do you just deal with the people that have been referred to you?
Yeah. I mean, so right now, our clinic here focuses more on the individual experiencing suicidal thoughts or who's recently survived a suicide attempt. But, over the years, I'm very frequently contacted by lost survivors, just to kind of, and oftentimes they're driven by the question, like, what happened? Like, why did this occur? And I think something that Erica noted before is it's such an individualized experience that oftentimes the answer when I meet with them is that there is no there is no rule book, so to speak. And along this line with that desire for closure, honestly, most of what I'm talking about with lost survivors is that I don't know that you'll ever have closure. But that's okay. It's just changing our understanding of what has happened and what that means in your life. And so this sort of, I think sometimes this pursuit of, I need to know what happened and why it happened, and I'll not be able to move on with my life until I do, in my experience, often is the target of grief work itself. Say that, how do we become comfortable with the unknown and the fact that you don't fully understand what happened, that's perhaps a tragedy of life, and you can kind of go on with your life, and you can honor the loss of someone you cared about, even if you don't fully understand what happened.
Interesting. Erica, you asked earlier if there were commonalities or characteristics of people that committed suicide. And I want to follow up on that because it just made me wonder when you asked that question. Does, if a family has experienced a suicide inside of their unit, does that make them more likely, less likely, or have no impact at all for other suicides? Do I learn? I don't know.
Well, it is interesting, Gray. I think same question, similar question on my mind for you, because when a family has survived one member's suicide, I think that does tend to put folks on high alert. Particularly if a parent dies by suicide, the surviving parent, I think, often has concerns about the children, whether there's a biological component or whether there's a social component or both. And I was curious if you could speak to that.
Yeah, so there is both biological and social component, and how I usually frame this for family members is that depending on the studies that you read, having sort of like a direct first order relationship with someone who dies by suicide, there might be anywhere from like a 2 to 5-fold increase in suicide for others who are closely related, which is fairly common for most medical conditions, right? But I always make sure to emphasize what that like means in like real terms. So again, if we estimate something like just a little bit less than 50,000 Americans per year out of 360 million die by suicide, what you're talking about is like a probability of 0.0001%, which means that now that doubling of risk is 0.0002%. And then because of, my training as a psychologist, I understand how people process information. Like, so that means 99.9999% probability that nobody else in the family dies by suicide. Okay. So we can't, 0% risk is just not a thing of anything in life. But let's just make sure that we're framing these like statistics in a way that I think is helpful for people, and that I find provides them the information that they need, and also I think helps them to not potentially sort of overreact or become so worried that actually can lead to other difficulties and problems. And then I think socially we know that exposure to suicide loss increases the risk of depression, suicidal thoughts, things like that. Julie Searle at the University of Kentucky has really been a leader in this research. And what she's largely found is that it's basically the closeness that we have to the decedents that is kind of the primary mechanism. And so when we lose someone we care about deeply, it impacts us much more than if it's someone that we were like an acquaintance with, that we were not perhaps as intimately connected with. But here again, we have to kind of keep those statistics in mind. Increased risk of suicidal thoughts and suicide attempts, sure, and also we're getting into these like small absolute values, and so perhaps we don't need to like put everyone on high alert necessarily.
But correct me if I'm wrong, suicide impacts men, or is there are more men that commit suicide than women, and I think it's by a huge margin. Why is that? First of all, am I right? Am I correct in my assumption? And second, why?
Yeah. So in all nations except one, and that's China, men are more likely to die by suicide than women. But women attempt suicide more often than men. Like again, the gender ratio is reversed. And the primary reason for this seeming paradox, it relates directly to the methods that tend to be used by men and women. So men globally, when they attempt suicide, they use highly lethal, dangerous methods, whereas women are more likely to use more survivable methods. And so in the United States, for instance, the reason why men account for the majority of our suicide deaths is because we have so many firearms. 55% of our suicides involve firearms, and 80% of firearm suicides are male. Women, by comparison, are much more likely to use medications, to overdose on substances, things like that. And that method is more survivable. And so that's why we see, clinically, again, in our hospitals and clinics, almost all of us will see more female patients who are suicidal than male patients. And that's because the men don't survive long enough to get to us, which really speaks to, again, those different pathway concepts I was alluding to before, and that arguably the people who are dying on their first suicide attempt are disproportionately men who use guns. And our traditional screening, detection, and treatment interventions will never prevent those suicides. And so we really do have to think about this in a different way for different people at different times.
So, fascinating answer, and it really drives home the concept of different pathways towards suicide. But you mentioned in every country except for China, it was more men than women. What's unique about China? Is there something cultural there?
That's the thinking. That I mean, right now the leading thinking is that there must be something kind of unique about Chinese culture that we see a reversal of the typical sex or gender rates. But I'll confess I don't do enough of multicultural research across nations to be able to speak more about that.
But if you looked at the statistics in the United States, people that are of Chinese descent, are there fewer of them?
Well, I mean, yeah. So if we look at different racial ethnic groups within the United States, we see, yeah, so people who identify as Asian in origin, I don't know what the exact percentage, but it's a small percentage. And in terms of rates, so if we look at suicide rates across different racial and ethnic groups, we see that the highest risk group in terms of percentages or rates of suicide is usually Native American or First Nation, followed by white/Caucasian, and then we see Black, Hispanic, Asian being a much smaller, lower suicide rates. Now, one interesting trend in the past, maybe like 10 to 20 years, is that we are seeing, particularly amongst Black youths, a faster increase in suicide rates, whereas for older whites, there's been a decline. And so we are starting to see, right, all these complexities, right, based on gender, age, race, so all these sort of different aspects of demographics can move in different directions at different times. Yeah, which has, I think, implications, right, for prevention.
So when you look at those statistics, you mentioned age. Correct me if I'm wrong, older people, older men, have a very high rate of suicide. Is that correct?
Yeah, very much so. So yeah, it's if you were to look at epidemiological data from the United States and kind of separate it by age bands or age grouping, something like that, what you'll see for men is that very low from 0 to about 10, and then you start to see suicide rates increase in pre-adolescence, adolescence, young adulthood. You get a little bit of a peak in about middle age, and then starts to come in or starts to decline in like our 50s, 60s, and then like above the age of 75, the chart just suddenly spikes, and it's like off the chart for those above 80 and 85. And the thinking, now I'll say, before I move on, you see a different pattern for women. And so for women in the United States, the peak, but here peak just means the highest level. It's not a sharp spike. It's kind of like a mound, right? Does also occurs typically in the middle age, so around 40s to 50s, but older women above 60, 70 doesn't have that same spike that we see for the men. Now, the thinking behind that is for older men, it's a constellation of factors, one of which is increased health and medical issues, which often goes hand in hand with access to medications. We have the gun issue as well, and the older a man lives in the United States, the more likely he is to be alone because he will have lost his friends, lost his spouse, all these other protective factors that would otherwise potentially prevent a suicide. So, yeah.
Fascinating.
We talk about protective factors, actually. We tend to think both clinically and more, broadly in the culture, that protective factors involve things like social attachments, social responsibilities, especially parenting, maybe religious and cultural beliefs against suicide. Has your career experience, your research, does that bear that out, that these protective factors are in fact meaningful?
Yeah, absolutely. And it's a really important part of, the treatments that we provide. I've written about and talked about how suicide prevention research for decades, you could argue, has been driven primarily by the question, why do people try to kill themselves, or why do they die by suicide? Something I kind of recognized many years ago, earlier in my career as a practicing clinician, was that question of why do people kill themselves was actually less helpful for me, as opposed to kind of a slight twist on that question, which is why do people choose to live when they want to kill themselves? Because from my perspective as a clinician, I'm trying to prevent suicide. So I need to know what holds people back. What is it that keeps them alive? And we have found in our research that treatments and interventions that really focus on identifying reasons for living and other protective factors and strengthening those serve a very, very pivotal role. And the patient feedback that we've received is that's usually when we ask a question such as like, what was most helpful for you in this therapy? It's always something that involves like reasons for living, protective factors, recognizing that even though things weren't going well in my life, things are going to be okay in the long run. I just needed to hang on for a few minutes. That this too shall pass. These sorts of kind of manifestations of like hope or optimism. These are, I think, really important parts of the therapy process. But I think we underestimate them because we think so much in terms of risk factors.
I noticed back when we were talking about screening, and you mentioned the endorsement of certain statements, maybe bearing some relationship to the risk for suicide. And I was noticing many of those statements were, I guess I'll call them extreme. I can't live with this, right? I'm probably misquoting you. I can't bear this. And is there a role for that too, in terms of working with folks who are at risk for suicide or who have attempted suicide, that kind of more extreme thinking?
Yeah, so the core mechanisms that we think underlie the therapies that we provide. So we do brief cognitive behavioral therapy for suicide prevention, or BCBT. We've also done a lot of work on crisis response planning for suicide prevention, and the underlying processes that we believe we are targeting that give rise to suicidal behavior are, first, challenges with emotion regulation. So being able to influence which emotions I feel, how long do I feel them, when do I feel them, things like that. But secondly, cognitive flexibility. And so this sort of rigid all or nothing mindset lends vulnerability, because people then, in essence, if you have an inconvenience or a slightly frustrating day or something like that, if you interpret that as this is awful, this is terrible, I can't handle this, then you kind of move from 0 to 60 really fast. And so a big part of the therapy that we provide is nuance. Is getting people to the shades of gray in between the extremes, so that when stress occurs, when misfortune or problems arise, you can, I think, better distinguish and realize that it's maybe not the case that you cannot handle this. This might be uncomfortable, unpleasant, undesirable. That doesn't mean that you can't handle it or it's too much to bear. And that seems to be a central change process that explains why the therapies and interventions work.
It's fitting. It seems well aligned with treatment for a number of conditions as well. Just cultivating the idea that I can live with some anxiety, I can live with some discomfort. I can bear that.
Yeah. It's, I would say one of the extreme thoughts that I would say is the most common one, actually, that we probably work on in therapy is I'm a failure. I'm thinking right now, the patients I'm working with, in every single one of them, like failure is like a main theme. And so we have these conversations about what does it mean to be a failure, and what is the evidence that supports that or disconfirms it. And usually what we find, right, is that it's things like perhaps mistakes or missteps that are reasonably common. All of us make these kind of silly mistakes in life. And And once we can reveal that in therapy and say, well, does that mean everyone's a failure? Most patients very quickly will say, well, no, that can't be true. And so we can then start to move to a space of perhaps it's possible to make mistakes and it have nothing to do with success and failure. Maybe it's just kind of a part of being human, and then we can remove the judgment from it. And so it's this sort of moving into the middle ground is a very, very, I think, important part of reducing long-term vulnerability to suicidal behavior.
Craig, if I could, I'd like to ask you just a few questions.
Mm-hmm.
Why did you get into this particular area?
Yeah, it was, it's sort of a series of, events, right? I think it was going to graduate school at Baylor University, and my director of clinical training was David Rudd. He was this internationally recognized, renowned suicide prevention and treatment developer. So I got to learn from the best. And then, I joined the military. That was also heavily influenced by David Rudd. But I joined the military right as the U.S. military suicide rate started to increase. So it became a focus of military efforts. And that's when we started our first BCBT treatment studies. And so there was an opportunity to start doing something about it. And I think the last event that really was pivotal to my focus was, while I was in the military, I deployed to Iraq. And so I was the sole psychologist at my base. And so I was pulling ER duty in addition to running a clinic. And, whenever people were suicidal, I was the one seeing them. And then also when people died by suicide, they were brought to our hospital and we would care for the bodies in order to, keep them functioning, to transport back to the U.S. for organ donation and, family reunions, things like that. And so I was, confronted. It was the first time I'd been exposed to dead bodies like that. And in a combat zone, everyone has a gun. And so pretty much all the suicides were guns. And so, I've kind of talked about as well tended to as our medical staff, provided to the deceased, you can still see the brutality of firearm suicide. And it's almost always self-inflicted gunshot wound to the head. And it's violent. And it was a very transformative experience for me. And to say this is not what I thought it was. And that's because most of us as mental health clinicians, if our patients kill themselves, it happens at their home. We don't see what it actually is. And so it personalized the issue for me. And definitely kind of, it also stimulated, incidentally, a lot of my, we're not doing this very well. And it got me to really question a lot of our assumptions about suicide.
Let me ask you a second question. Your point about failure in your current client base, I could see where that would be a significant issue. Does that argue that the teaching of resilience or the focus on resilience in mental health is absolutely positive, and should we double down in that particular area, or is that just totally irrelevant?
Yeah, I think it's a hard question to answer because I think it's a complicated matter. And what I would say is that there have been enough studies now published in the past maybe 5 years to 10 years that have certainly caused me to not be so confident in the whole notion of resiliency training and prevention. And so where I think the most work around this has been doing prevention programs, resiliency, educational type stuff in our schools, get in early, help out our kids, set them on the right path in life. And there are now an alarming number of studies showing that resiliency-focused mental health programs in schools, in community settings, perhaps more broadly, either have no impact whatsoever and or also seem to increase depression and anxiety and things like that. And none of us really knows why that's the case, but I have seen some colleagues speculate, and I think maybe they're right, that when we do this, we actually inadvertently disrupt people's natural resilience. And we teach them to ruminate and focus on experiences that perhaps they otherwise might not give a lot of weight to. And so are we, and it's just interesting that in the past 20 years or so, we've been increasingly more awareness, more prevention, more resiliency training, and the rates aren't heading in the right direction. So, yeah.
Interesting.
Yeah.
Erica, before I ask everyone to summarize, do you have specific questions you would like to ask?
Yeah, so my question for Craig, and I'm going to root this in. So one of my earlier training experiences when I was in grad school, also, in the time frame you're talking about, 20 years ago, there was rates were raising and there was increased awareness. So I did a practicum at a university that in the year before I was there had experienced, I believe, 5 student suicides in 1 year. And interestingly, to your point earlier about how folks with suicidal ideation do not always present for therapy, or often do not, none of these students had contact with the counseling center in that year. But one of the sort of, I think, questions for those working in the counseling center, and I've seen this mirrored other places since then, is when there is a suicide within a community, whether that's a school, a workplace, how is it handled afterwards? How openly is it discussed? What is said about it? So, we're living in a time where there's more openness around suicide. We see it named now in obituaries where that wouldn't have been the case in the past. But I think the question still sits here for people, for myself included. How should we talk about it? How should we talk about it? People worry about the copycat or contagion factor. And I was curious if you had any thoughts around that.
Yeah. It's a question I don't think we really have a clear answer to right now. And I think it kind of speaks to the fact that it's like how we talk about it probably matters. And then I think it also is heavily influenced by the individual differences of the people receiving the message. And so what I can say is that one thing that I've worried about is it's almost like because we are so hypersensitive to the issue, do we inadvertently and subtly communicate that there is something wrong about this? And so there's sort of like this paradox, our anti-stigma efforts, does it actually maybe increase stigma, or does it short circuit or work in ways? There's been a sense of, many of us as suicide researchers have talked about, is we've definitely changed how youths today talk about mental health, talk about suicide, things like that. And so is like what it means to be suicidal today different than what it meant to be suicidal 20 years ago? And what does that mean about how we adapt and adjust all of these issues, our prevention strategies, how we talk about it, things like that? And so there are people who have expressed concern, have we destigmatized suicide? Have we normalized it to the point that it no longer is taboo? Does that make it easier for people to act upon suicidal thoughts? And I don't know if there's a clear answer to that, but I will say, I think it's not a concern that we should dismiss per se. And so all of that is to say, I think what that means for us as clinicians is that, how we approach the issue clinically now is quite different than 20 years ago. And we will have to adapt and evolve our methods accordingly. And so the last thing I'll say about that is I talk about this issue with students and trainees, and others, who work on our team. And a point that I make pretty routinely, they probably roll their eyes if they heard me saying it again. But it's like, if we're practicing BCBT or we're doing the same things 20 years from now as we're doing it today, I would say that we have failed as a profession, because what that means is we have not learned and we've not updated anything. And so with that in mind, I think maybe the final thought on that really is just like recognizing that suicide as a phenomenon, because of the social cultural linkages with it, can evolve over time, and we also have to evolve our models and our treatments and our prevention strategies as a result.
So I want to be respectful of everyone's time. So I'm going to give each of you an opportunity to kind of summarize. Craig, I'm going to give you the last word, so you'll go last. Erica, you will go first. But before you summarize, I just wanted to say, from a personal perspective, I have seen the devastation of that's occurred with lost survivors, somebody that, family members that were left behind. Also, the devastation that's occurred when there's been attempted suicide, the devastation of the family. Okay. Mental health, if there are established grief techniques that could help people move past this, be able to continue to be productive in their own lives, live in balance, as you might say, Erica, I obviously would encourage lost survivors or family members to do that. But Erica, what's your summary?
Yeah. So Craig shared a number of things with us today from his work that maybe don't defy or don't align entirely with some prevalent messages about suicide over the last couple decades. But I appreciate him being here, and I appreciate you, Craig, sharing these. You close with the message that we as a field need to continue to learn and grow and evolve. This problem will likely continue to change and evolve. And really, especially salient to me in that idea is what we talked about earlier for lost survivors. Because as we said earlier, we've lived with this message that there's always warning signs, this can always be prevented. And I know it's very difficult to sit with the idea that there may not be warning signs, or that in some cases, maybe prevention was not what we thought it would be. And I still think that message is so important because, as a field that wants to serve not only those who may be at risk for suicide, but those who have survived a loved one's suicide, I do think this broader understanding is so important, really crucial to our efforts to support those who have survived a suicide, who maybe have gotten messages that don't align with their experience and their reality. And so I appreciate you being here today to share that from your work with us.
Craig, last word is yours.
Sure. I think maybe what's coming to mind at the end of our conversation is, I often, and something else I often teach to trainees and students is that there should be two questions that we should always be asking when it comes to kind of big issues like this. The first of which is, how do we know? And the second is, what if we're wrong? And I think the first question really speaks to the importance of basing our ideas, our practices, our strategies, in empirical data. Because if we're not basing our actions and decisions on things that have been shown to be effective, or at least relatively better than something else, then we're probably not going to be very successful at preventing suicide or doing other things that we hope to accomplish. But we need to counter that, or sort of counterbalance that desire with that second question, which is, what if we're wrong? Because part of the scientific process is being wrong. And the scientific method is self-correcting. And if we're unwilling to say, well, gosh, that didn't work out, then we will get stuck. And that can hurt a lot of people. And so we have to be sufficiently humble to recognize when something that feels right perhaps isn't actually working all that well. And it's okay to own that and to move on and to try something different.
Great. Thank you very much. Let me say that our sponsor today is Equilibria Psychological and Consultation Services. It's an insurance-based provider whose mission is to help individuals achieve their personal potential and long-term growth by compassionately and respectfully helping clients live in balance. Visit equilibriapcs.com, equilibriapcs.com. You can look for them on Facebook, Instagram, and LinkedIn. You can also look for me on Instagram, Daniel J. Gomez 24, and on LinkedIn. Now for the disclaimer. I am not a medical professional, and I am not providing medical advice. The opinion of our speakers is solely their own. This podcast is copyrighted and cannot be reproduced without the express written consent of EPCS Management, LLC.